and I know what clinically works and doesn't work. After over 30 years of practice, we really developed our techniques to be very predictable. The most important thing is the final clinical result. And the positive clinical result is based on the products that you use. I'm not a salesman. All I'm doing is trying to show you what works in my hands. And certainly, I'm a general dentist in Detroit. If it works in my hands, if the techniques are done properly, it can work in your hands. And we have to realize that dentistry is going so fast. And I appreciate the hundreds of you that are listening to me in learning a new technique or a better technique or a technique that's going to save your body and help boom your practice or take your practice to the next level. This isn't an implant program, but dental implants is a very important part of my daily practice. So I'm going to show you some completed cases. We'll just do it quickly. I'm not going to promote any particular brand or anything like that. What I really want to do is set the foundation to build the final house. The style of the house that you want to have is going to be up to you in the future. So let's go through clinical cases. I think that's the best way to learn, and I think that's most appreciative. So let's look at our first case. Single extraction and a simple graft. So we have a tooth that is deemed non-restorable. I hope all of you who are seeing this radiograph agree. Certainly, maybe some of you would want to do a root canal, crown lengthening, cast post and core, and a crown. This tooth is mobile, grossly decayed, as you can see. Now, we have an implant next to it, an implant that was placed somewhere a long time ago. We have some wearing of the natural teeth, and we may feel that this is a difficult extraction. There's a lot of bone to work with. Some of you may say, well, that's not so difficult. I would probably challenge you that most of you listening, in removing this tooth would take a periosteal elevator or a periotome and go into the sulcus and try to break the periodontal ligaments. You would probably, I assume, take a luxator or an elevator and try to get some movement of that tooth. Again, as we look at it, it's very decayed, soft, very possible that the coronal portion of that, what's left of that tooth, could fracture, which means that we would go in there and remove bone to remove the tooth and possibly damage that site. So I'm going to challenge you with a new technique or a different technique. The most important thing here is there's very little lingual bone, and so I'm going to take a 557 surgical burr, which is just a long 557 burr, and I'm going to create a purchase point onto the lingual surface of that root. I'm not taking bone away from the lingual surface. Rather, I am simply preparing the root structure on the lingual surface of this tooth, creating a flattened edge. And let's look at this graphic here. What we're doing is we're taking a burr, and let's see if we can get this to work. We're taking a burr, and I'm flattening the root structure, simply creating a purchase point, a flattened edge. We'll then take our physics forceps, which I'll describe in a few minutes, which consists of two components: a beak, which is going to engage the lingual surface of that root, and a bumper, which is placed as deep into the vestibule as possible. And with simple rotation of the wrist, no forearm, no bicep, no shoulder pressure, no squeezing, no pulling, no tugging, simply rotation, creating tension on that lingual surface of the root, will allow that periodontal ligament to break down physiologically. That tension created on that root actually creates an enzyme which will break down the periodontal ligament. If the periodontal ligament is destroyed, the tooth will come up and out of the socket along that arc of rotation of the forceps. And we'll describe that in a few moments. So the instrument, the physics forceps, there's 4 instruments: an upper right, upper anterior, and upper left, and a universal lower physics forceps. And what we do is it has 2 components. As I said, it has a beak, which is like the shovel-shaped flattened edge, which is the working part of the instrument. That part of the instrument will engage the lingual or palatal aspect of a root, subgingival, 1 to 3 millimeters subgingival, onto the root structure. The bumper consists of a bulb, so to speak, and we do have a bumper. The bumper is this little green piece here that's a little silicone covering. The bumper is not the working end of the instrument. The bumper is simply the center of rotation that the tooth will disengage around that arc of rotation, similar to the arc in the design of the forceps itself. So it is not the working end of the instrument, rather it is a fulcrum. It's a center of rotation. It is not, you're not squeezing the instrument. It's not like a conventional forceps whatsoever. The handles are very lightly held, and the movement is simply rotation of the wrist, creating tension onto the lingual surface of that root. So here the bumper is placed onto, or the little silicone cap is placed onto the bumper part of the instrument, and now we have a working physics forceps. And here this schematic clearly demonstrates the position of the beak. The beak is placed on the lingual or palatal aspect of the root, 1 to 3 millimeters subgingival onto the root structure. The bumper is simply placed as high up or down low into the vestibule as possible. It is a center of rotation of the arc of the design of the instrument. With tension placed on the lingual or palatal, the periodontal ligament will break apart, and if there's no periodontal ligament, the tooth will elevate up and out of the socket along that arc of rotation. The instrument is not intended to remove the tooth in total, rather it's intended to luxate the tooth 1 to 3 millimeters out of the socket. We will then take what we call a tooth delivery instrument to remove the root in total. So as I mentioned, physics forceps, the standard set, and I'll let Kurt discuss this at the end, the products, but there are 4 instruments in the standard set: an upper right, UR, upper left, UL, upper anterior, UA, and a lower universal. And they're designed specifically for different parts of the mouth. So going back to our original tooth, remember we had a very decayed lingual aspect of a root. We're going to engage the beak onto that flattened surface, the lingual surface that we prepared. I'm then going to position the bumper as far down the vestibule as possible. And you can see it's down. It is not a working end of the instrument. And all I'm simply doing is I'm not squeezing the handles. I am simply rotating my wrist towards the patient's shoulder. The bumper is simply a center of rotation. It's not affecting the soft tissue. It's not affecting the bone. In a matter of a minute or two, that tooth will start to come up and out of the socket. And in our courses, and we'll talk a little bit, or Kurt can talk a little bit about our live patient courses, we do 2. We have an atraumatic extraction with physics forceps at the University of Detroit Mercy School of Dentistry. We will probably see normally about 80 patients. Our class sizes are limited, and every doctor will be able to remove countless number of teeth using the physics forceps. And you can see with the pink arrow, I am not squeezing the instrument. I'm just holding it firmly and rotating my wrist. The instrument is not intended to remove the tooth in total. We will then, it is intended to luxate the tooth 1 to 3 millimeters up and out of the socket. We will then take a tooth delivery instrument to remove the tooth or root completely out of the socket. Now, we have a socket. We simply have a waffle cone, so to speak, or an ice cream cone, or a cereal bowl. And it's imperative that we remove any granulation tissue. Purple blood is infected blood, is not healthy blood. So we want to take a sharp curette, and I think Kurt will discuss, we put together a nice grafting kit for you, but I'll let him describe that a little bit later in the program. But we'll take a sharp curette, and I will curette the granulation tissue out of the socket. Now, you guys, everybody who's listening today is going to want to have this product. When all the walls are intact, when we have a waffle cone or an ice cream cone. This product is called Osteogen from Implant and from Golden Dental Solution. Comes in two sizes, a large and a small, and it is calcium and phosphorus. It's non-sintered, which makes it different than the other synthetic materials out there, and it's in a collagen base. It's a bovine Achilles tendon collagen. It's rather firm. It can be molded, but it is just a really wonderful product I found to graft a simple socket. So I'm going to take this little plug, as we call it, and we just described that. There's a small and a large, and I will simply, very gingerly, place it into the socket. Now, this material will actually contour as it soaks up blood to the design of the socket itself. And what's remarkable about it is that we don't need a membrane to protect this material. We don't get epithelial invagination into the crestal aspect of this material. It's pretty special. And I can honestly say that because we've been using this for quite a while, and we've done countless histologic evaluations of my socket sites as I'm preparing for dental implants. And we do get formation of bone in a very, very short amount of time. In 3, 4, or 5 months, we have actual replacement by the patient's bone. So here I'm taking this Osteogen plug and packing it into the socket, and I'm going to just simply suture it into position. As I said, this is a unique product in that we don't need a membrane to cover it. And the other techniques that I'm going to show you through the program, we do need a membrane or a barrier to protect the graft material from invagination of soft tissue. So we'll talk about that in a little bit. So here I just took these are micro sutures, it doesn't really matter, and I just made two cross interrupted sutures just to hold that membrane in place. Now I will tell my patients that the graft material is, number one, a synthetic, number two, it is white in color, and so I tell them that white color material needs to stay in place. I don't want them to think it's pus, and I don't want them to be poking it. I see all my patients in about a week, and I will remove these sutures, and this is what the graft looks like immediately at placement. You can see it's rather opaque. I'm sorry, it's rather radiolucent in the socket. You can actually still see the socket in position. And what will happen, what's nice about this is we get a very objective determination over a period of time. So you can take a radiograph and actually see the transition of that radiolucent grafted site into a more opaque, natural-looking bone site. After about 3 months of healing, you can see how this socket is starting to regenerate into bone. Now, how does a socket heal? A socket heals from the apex towards the crest. So the bone is more mature at the apex of the socket than it is at the crest, and you can see how the crestal area is still a little bit radiolucent over a period of time. You can see how the tissue epithelium attached gingiva covers over the socket site, and now we have a site that is relatively ideal for placement of a dental implant that all of you out there with a little proper training could provide your patients. And believe me, your patients want you to do this type of work. So we have attached gingiva, and again, not going into specifics with the system, but with every implant system we have a pilot drill. This happens to be the Han system. It's a 2.2 pilot drill that I will penetrate to depth and angulation, mesial distally. Again, we're not going to go into specifics about my techniques. We can teach you that in another course. We're going to widen the osteotomy, and you can see how we harvested bone from that site. Maybe a little bit immature bone, but needless to say, it is bone formation. We confirm our positioning with radiographs, and here is the Han dental implant being threaded into the surgical osteotomy site, and we get initial torque of 45 Newton centimeters. That's tremendous initial stability. If that was mush, we would not get that stability. So I'm very impressed by the material. Immediately after placement, this is a flapless procedure. You can see the implant is ideally placed, very little bleeding, and believe it or not, our patients do not experience discomfort with this procedure. We just don't give narcotics very often. 600 milligrams of ibuprofen is adequate for any type of pain relief. And when your patients have a positive experience like this, a positive experience in an atraumatic extraction where they don't even realize that you took the tooth out, a positive experience in placing a dental implant and then naturally restoring them. Again, very professionally rewarding and very financially rewarding for you out there. So here's our implant. Because we got initial stability, we put a tall healing abutment, which eliminates the need for a secondary surgical procedure after integration of the implant into the bone. It's important, depending on what type of material you want to use will depend on the defect that we have in the bone. As I mentioned, when you have all four walls intact, you're going to want to talk to Kurt about the osteogen product. It really is something, and it really does work. But there are cases that are more complicated, and I think you need to see that also. So let's look at a single extraction, and again, a simple graft. We have a tooth that was deemed non-restorable, an implant that was placed many, many years ago. And we decided we're going to remove this tooth and potentially place an implant in the future. We have the crown, and again, very simple. We're going to take our lower universal physics forceps. We're going to engage the beak onto the lingual surface 1 to 3 millimeters subgingival. We're going to put the bumper where? As far down the vestibule as possible, not squeezing the handles, rather just simple rotation of the wrist, putting tension onto that lingual aspect, and very important photograph here. This is a very important photograph. Do you see how that tooth is coming up and out of the socket? It's not coming facially out of the socket, rather it is coming up and out of the socket, following the same arc of rotation as designed in the instrument. Again, the physics forceps is not intended to remove the tooth in total. It's intended to luxate the tooth about 1 to 3 millimeters. I'll then take a tooth delivery instrument and simply pull that tooth out of the socket. Okay, and here we'll curette. We'll curette, get all that granulation out. We have a socket site, and again, here's our osteogen plug that I will place into the socket. Firmly place it. I'm not packing it like amalgam, rather than firmly placing it. You can see how it looks in the mouth, and simply taking my surgical, my suture. Now look specifically. This is a really great photograph on how I suture. One of the issues that many of our doctors in our training have is they grab onto a membrane and they pull it out when they suture. Because our needles now are reverse cutting, I like to take my needle holder and actually place the needle from the crestal aspect towards the facial. Then I turn the needle around and go from the crestal aspect to the lingual or palatal. This eliminates grabbing onto the graft material or to the membrane, and allows me to suture very, very nicely. Here you can see I'm going from the crest to the lingual, and simply placing some cross sutures just to hold the grafted material in place. I will remove these sutures in 1 week and allow the site to heal. We'll give it 4 or 5 months, and then we have an ideal site for a dental implant. If we did not graft this site, potentially the bone is going to shrink down and in, which could prevent us from placing implants predictably or complicate the dental implant placement in the future. Initially, the material looks a little bit radiolucent, but over a period of time, it will become more opaque. Now, oftentimes, we just can't use the osteogen. If we lose the facial plate of bone, I will graft and place a membrane. So let's look at a case that was referred to me. I did not restore this case, but we have a cuspid tooth that was deemed non-restorable and required extraction. Now, again, let's look at how we would conventionally do this. Many of you would take a periotome or periosteal elevator, go into the sulcus, and then take a luxator elevator and try to luxate or elevate this, and then grab onto it with a forceps and squeeze like heck, and either figure eights or buccolingual, mesial distal, try to get that tooth out. Potentially you could damage the porcelain on either side. So let's show you the technique that I use. We have a root canal tooth with a post. Don't we all love posts, right? We have a horizontal fracture. You can see it right beneath the post. So this can be a difficult extraction for many of us. But with the physics forceps, because you're not putting any physical force onto the facial and palatal aspect of the root, you're only putting tension onto the palatal aspect, we're able to remove this tooth in total without fracturing the root and having to dig out that remaining root. We have the Vatek CBCT in our office. We do a lot of implants, and I just have this photograph to show you how thin that facial plate of bone is. In the premaxilla, the facial plate of bone can be extremely thin, but we want to remove this tooth. Another great instrument that we use every day in our practice that Kurt with Golden Dental can talk to you about is called a Vibroject. It's a little instrument that attaches to your existing syringes, and it's battery operated, and you turn it on and it vibrates not only the base of the injection, but also the needle. And physiologically, motor sensations is faster than pain receptors to the brain. And so, many of us will shake the lip or have different techniques to distract our patients, and that's the theory behind this. Again, my staff loves this because we know it works. Our patients are very, very responsive. And I can honestly say about 80% of my patients notice a significant decrease in discomfort on our injections using this product. So it's, again, something you may want to look at in the future. So here again, we're going to place our beak 1 to 3 millimeters subgingival onto the palatal aspect of the root. Place our bumper as high up the vestibule as possible. We're not squeezing the instrument. I'm simply rotating my wrist here towards the corner of the eye. And what our hope is we're creating tension onto that palatal aspect. There's no force on that bumper. Okay, we're not squeezing the bumper. We're not damaging the bumper. We're not hurting the bumper. And in a matter of a minute or two, that tooth and root will come up and out of the socket. I'll take my tooth delivery instrument and look at that curved root. Remember, we had that horizontal fracture. It was deemed non-restorable, and we were able to remove that tooth atraumatically. Now, atraumatically to the patient, atraumatically to the bone, and atraumatically to the dentist. But even more importantly, in the aesthetic zone, it's imperative that we maintain facial plate of bone if we can, but it's imperative that we maintain the interseptal bone. That interseptal bone is holding that interdental papilla. And if we don't want blunted interdental papilla, we have to maintain bone. Traditionally, if you fractured the coronal portion, you would take a burr and you would grind the heck out of the bone, and you would probably lose some of that interseptal bone. And here I did, again, for education purposes, we took another CT, and I just want to show you that facial plate of bone is intact. It's thin as heck. We removed the tooth, but quite an experience for the patient. Our typical radiograph, and we're able to graft and place an implant in that site very predictably, simultaneously. In my office, I carry a variety of products. They're all from Golden Dental. I have the osteogen plug, which we already talked about. I want to have an allograft. An allograft is human bone. It's harvested from a cadaver. It's very safe today. All our allografts are FDA controlled, and they all come from just a few sites around North America. We'll use mineralized cortical cancellous. Cortical is hard bone, right? The cortex. Cancellous is more porous. Allograft material. And what that means is that we will get resorption of that material. Osteoclasts will eat it away. Well, what do you think is going to be eaten away quicker? Well, the softer, porous, cancellous bone. The cortical bone will take longer. And I want that differentiation. I don't want the material to change over quickly, because that's when we can have a incomplete or unpredictable osteogenesis. So an allograft material, either in a putty form that you can inject or in a powder form that you can mix with sterile water to create your own putty and take it to the site. We'll demonstrate that in a few minutes. The third product that I have in my practice is tricalcium phosphate, and I like the product from Searsorb, or it's called Searsorb. It's from Curasan and from Golden Dental Solution. It is a synthetic material, again, calcium and phosphorus particles that I will mix with the patient's own blood. And my patients respond very well to this. And I have found over the last 10 years or so that it's worked very, very well for me. Many of our patients don't want a human source or an animal source. And remember, the osteogen plug is in a bovine matrix. And so having a truly synthetic material made in a dental laboratory is certainly an option that we have. That's what I use. I have 3 products in my practice: allograft, the synthetic, and the osteogen plug. Keep it simple. This is how a putty comes. It's in a collagen matrix. It's allograft material, and it allows us to inject this putty. It's probably the most convenient way of distributing a graft material, but it's also the most expensive method of doing that. So I do use it. It works very, very well. And in our courses, this is what everybody wants to use first. So we let everybody use it, and then we train you on the more conventional techniques. Going back to our case of our cuspid, again, for demonstration, for education, I just made a very quick envelope flap. I wanted to show you that facial plate of bone remained intact. And it's there. And it was a very atraumatic extraction. Atraumatic to the patient, she was amazed. Atraumatic to the bone, atraumatic to the interseptal bone. So very important. Now, when we're using a membrane, there's various types. There's a lot of membranes out there. And again, I'm going to keep it simple for you. I think that probably the best material and best membrane in my hands is called EpiGuide. And again, it's from Golden Dental Solutions and from Curasan. It's a trilaminar, long-lasting, resorbable membrane. Now, without getting into too much complication, what the literature will say is if we can get closure, soft tissue closure within 2 millimeters of our membrane, we can use a resorbable membrane. However, if we cannot get closure within 2 millimeters, say in a maxillary molar area, then theoretically we want to use a non-resorbable membrane. Now, a non-resorbable membrane will be removed in about 6 weeks. The thought process behind a membrane is to prevent invagination of epithelial tissue into our grafted site. We're making some concentric circles here. When we graft a site, it heals from the apex towards the crest. Epithelium grows about 10 times faster than bone, and what we want to do is prevent that epithelial tissue from growing down into the crestal site, which can cause a defect, which can cause bone loss, which could cause failure of your graft. And that's why so many hundreds of you are listening to me today, is because you haven't had predictability. And I'm telling you, if we use the techniques properly, you will have 100% predictability. So if you want one membrane in your office, EpiGuide is a great one because it lasts anywhere from 8 to 12 weeks. It will not be resorbed by the oral environment. I remove my non-resorbable membranes about 6 weeks post-op anyways. So if I have a material that will last over 6 weeks, it kind of acts like a non-resorbable membrane. Your choice, but again, I'm going to tell you what works best in my practice. So here, in this situation, I wanted to demonstrate, same cuspid case, the use of the EpiGuide material. We measure twice, cut once, and I'm going to place my membrane passively. Again, in our demonstrations, in our courses, this is probably the #1 reason why graft techniques have not worked for you. When we're protecting the graft, we want to use a membrane, but that membrane has to be placed passively so that it doesn't come out. I showed you a suture technique that you can suture, go from the crest to the facial, turn the needle around, go from the crest to the palatal in this situation to hold that membrane in place. We want that membrane to be placed at least minimally 2 millimeters past any defect. Didn't really have a defect here, but again, I wanted to demonstrate the technique. If you lost a facial wall, let's say you lost 6 millimeters of facial bone, how far would you place that membrane? You have to place it at least 2 millimeters beyond the defect. That's a rule that cannot be broken. But look, there's no hands, there's no forcing. That membrane isn't going to go anywhere because it's very passively placed. Here I'm taking my allograft putty material and I'm injecting it into the socket site, packing it firmly, not like amalgam. And we have our site, and I did my osteotomy. I'm going to thread my implant right into place. We're going to use the suture technique that I demonstrated earlier, and we're going to hold that membrane in position. Now that opening is greater than 2 millimeters, but it's a long-lasting resorbable membrane that I feel very comfortable with. It's going to prevent that epithelium invagination into the grafted site. Post-operative implant placement, again, I won't go into too much detail about our implant placement. That's a whole nother course, but you can see the grafted facial aspect of that implant. It's just a perfectly placed dental implant. After it heals, we give it 4 months to integrate. We expose the implant, and we will make our final impression. And some of you, a lot of people ask what kind of material. And if you want to write this down, this is the time to do it. Panacell, it's a material from Kettenbach, Kettenbach. And I'm sure Kurt could provide you this information if you needed it. It's sold directly. It's a German, high-quality German product, different viscosities, polyvinyl siloxane. Also, they have what's called Silginate, which is a polyvinyl siloxane alginate material. Again, I'm not going to go into too many details with this, but it's what I use, and it gives me just great results at minimal cost. And why wouldn't you want to save money on something that you're going to throw away after you're done using it? So you may want to look into this. Very much worth the price of admission of this webinar. And here's a putty. And we use a wash. I use a medium body and a putty when I do my implants, and I get a high quality impression. The abutment is fabricated and a crown is made, and you can see our implant retained crown probably looks better than the little bit of gingival irritation around the other natural crowns in her mouth. So let's talk about graft instrumentation. It's very important that you have a kit, and Curtin and I created a grafting kit that I'm very proud of. We try to keep the cost down, but also try to provide you a high quality product. And you need the right instruments, and it's the instruments that I use in my grafting. And if you're going to do an extraction and a grafting, you ask your clinical staff, bring me the grafting kit. It's all there. You don't have to hunt for anything, and you know you're going to be able to do this work in a high quality. We have a curette, and you can see the blue anodized heads, which give us tremendous longevity. We have a spoon and a packer that allows me to take the graft material to site and to firmly pack the material. We have a periosteal elevator. We have an Orban knife, and we don't have time to discuss all these instruments in detail, but an Orban knife is a wonderful tool. If you don't use it, Google it. It's a very sharp blade, allows me to make nice incisions around teeth, and gives me a lot of control in my atraumatic incisions. We have a little dappen dish that allows you to mix your grafting material. We have a bone file to remove any bone spurs, a nice pair of sharp scissors, and I know there's a lot of needle holders, but we try to give you kind of a universal one that's inexpensive and easy to use. Obviously, you can use what you feel is most appropriate. We have a tissue forceps and then a surgical blade holder for disposable blades. And it's held in a nice stainless steel kit, easily sterilized, keeps all your instruments in one little packet. All right, let's keep moving along here. We're going to do some extractions. We have a tooth that was deemed non-restorable. We have a distal defect, and I'm going to move a little quicker. We're going to remove this tooth, again using the physics forceps. And if you look on the facial aspect, you can see a little pus coming from that area. We're going to engage the palatal surface of the root on the 1 to 3 millimeter subgingival, put the beak as high up the vestibule, rotate your wrist, do not squeeze the instrument. We're rotating towards the nostril, the nose area, that tooth, and I'm not squeezing, I'm just holding those handles firmly but not squeezing. The tooth will come up and out of the socket. I'll take my tooth delivery instrument, remove the tooth, and we have a socket. Or do we? We take a radiograph, make sure we got the tooth out in total, and look what happens when we curette. We have a facial defect. Now I've already alluded to how to take care of this. We're going to take our Orban knife, we're going to make some clean incisions, we're going to elevate that soft tissue beyond the defect, at least 2 millimeters. Here we're taking our graft material, I'm wetting it, and in wetting the allograft material, it kind of becomes a putty. I'm taking my EpiGuide material, again, measure twice, cut once. I'm wetting it, and here's my Orban knife. I'm going around the tooth, making a very clean incision and elevating, making what we call an envelope flap. I haven't made any vertical incisions here, and I'm elevating that soft tissue beyond the defect. I'm going to immediately place an implant. Again, you may decide you want just to graft it, not place an implant. And again, without getting into details about the surgical technique, I'm penetrating the bone onto the palatal aspect, about 3 millimeters palatal to the facial aspect of the adjacent teeth. And I'm going to widen my osteotomy, and I'm going to harvest the bone, place my implant. I'm torquing it into position. I want you to clearly see this photograph. There is no bone on that facial aspect of that implant. I hope you all agree, because there's a defect there. We're going to put a cover screw. Simply take your membrane and make sure that you place that membrane at least minimally 2 millimeters beyond the defect. If you do this and you passively place your membrane and you use your graft and you suture correctly, you will grow that facial wall 100% of the time. So you can see my membrane is very passive. I'm going to take my graft material and place it between the implant and the membrane. I'm going to fold my membrane over the top and suture it into position. You can see that we've maintained some semblance of interdental papilla, and will allow this site to heal. The grafted material around the implant will form bone. 1 week post-op, patient was wearing a flipper. That was what was fabricated. We remove the tissue. This is what it looks like. It's a little angry. The epithelium wants to grow into it, but that membrane is preventing the epithelium from penetrating into the graft site. And after 4 months, we can see how the tissue is healed. We'll do a tissue punch. We can see our nice gingival cuff formed. We make a nice zirconia abutment. Look at my margins. My margins are at the gingival line angle. We don't do subgingival margins. I'm not concerned about cement penetrating into the sulcus, creating periodontal problems. The implant is ideally placed, and a crown is cemented into position and beautifully. And this is something that all of you out there are certainly capable of achieving. Here we have a tooth that is again deemed non-restorable. It's broken down at the gum line, and this is another set of instruments created by Golden Dental. They are called separators and a bayonet, again anodized in blue, and they're very, very thin, very strong though, and you can see the teeth on the one instrument, which allows us to elevate that root very easily. And I'm sure Kurt with Golden Dental can describe it. You see we have a very decayed tooth, but I'm able to get between the tooth and the bone and create some space, and I'm able to take my bayonet and elevate, create a purchase point for my physics forceps, not squeezing, and remove that tooth very atraumatically in a matter of minutes, doctor, in a matter of minutes. So again, when you have the right tools, it makes your job that much easier. We'll graft, we'll place a membrane just as we discussed, and possibly place an implant in the future or at the same time. Now, one of the other instruments that I want to talk about briefly is the Wham Key, and those of you who haven't seen it, you should really look into it. When you're removing a crown, I know we never remove our own crowns, we remove other doctors' crowns all the time. I'm assuming that most of us take some type of a burr, and we slice the crown from facial to lingual, and take some type of instrument and break it apart. And that's fine. It's time consuming, but with our zirconia crowns, our Bruxer crowns, that can be very, very time consuming and very expensive use of burrs. So here we're using what's called a Wham Key, and it's a series of 3 instruments that have a little ball on the end. And what I'll do is I'll make a little opening onto the facial where I think that the occlusal preparation would be. Now, I'm assuming with a PFM or a Bruxer crown, the occlusal preparation is going to be about 1/3 down the occlusal table. So I'm guesstimating. And I'm simply going to make a small opening, take the Wham Key, place it into that opening to the central groove area, and simply rotate my wrist, and that crown pops off. Now this is magic. You know, it's just incredible. If we're going to redo this crown, we would prepare the tooth, and your staff can use this as a temporary. It's the best temporary you can make. Put a little composite or acrylic into that facial aspect, and you have a nice long-lasting temporary restoration. In this situation, this tooth was deemed non-restorable, so we're going to remove it. Now, in our mandibular molar teeth, I will almost always section the roots. Section the roots through the furcation, and then remove the tooth using the physics forceps as if they were single-rooted teeth, single-rooted bicuspid teeth. And it makes my job that much easier. So we made a slice through the furcation, take my physics forceps, and simply elevate the 2 roots independently, very atraumatically and very simply. We can graft, we can then do what we need to do. So in a quick summary, physics forceps, I wouldn't work without them. I would not work without them. You know, we all have a myriad of a big bucket full of extraction instruments. And we have that because we have a hard time removing teeth. But if I'm going to remove an upper right bicuspid tooth, I ask my staff for the upper right physics forceps. Graft material, I'm a big believer, keep it simple. We don't want to spend a lot of money, nor do we want to have too much product on hand, depending on how many grafts you do. We talked about the osteogen plug, we talked about the tricalcium phosphate, the Cerasor material, and then we talked about allograft material. We talked about membranes. There's 2 types of membranes, resorbable and non-resorbable. And if you wanted just to have one, I suggest the EpiGuide material, which is a very long-lasting resorbable membrane. Make sure you have the right instruments. Having a grafting kit on hand, I think, makes you very, very efficient, and time is money in your practice. Know your limits. I think as general dentist, I know what I do well, I know what other people do well. I know that I can graft socket sites with all the walls intact, and I know that I can graft a facial defect predictably to the nth degree as long as I use the proper techniques. We do teach a live patient program on grafting. Dr. Ara Nazarian and I. Ara is just a wonderful educator. We do a 2-day program in the city. We do it at one of the nicer hotels, day 1, and one of the nicer hotels in the city. And on day 2, we take you to our university, where all the doctors will will extract teeth, have facial defects. We'll use 3 types of materials, maybe 4 types of materials, and 2 types of membranes. We'll teach you suturing techniques and anesthesia techniques, and it's just a wonderful way to learn. Detroit's very easy to get to. The airport is very accessible. We have wonderful airports, and the city is booming. And you'll have a good time in our city. You can do these cases. I know we went quick today. It's a quick hour program. Come join us in one of our other programs where we can spend a day or 2 days with you and really make you proficient at these techniques. So what I'd like to do is turn it over to Brian and Kurt, and if there's any questions, and then Kurt, I think probably has some specials. I don't really get involved with that, but he can describe them. And are there any questions?
Thanks, Tim. This is Kurt Lawler with Golden Dental. I'm going to get my slides up here, and I'll go ahead and get started with my aspect, which is pretty quick. All right, so I wanted to just clarify a couple things with the products, like Tim said. Tim obviously did a great job going through a lot of the cases, showing some of our products that we do offer here at Golden Dental. You know, a lot of what Tim showed, we cover in our programs, our continuing education programs, which can take anywhere from a full day to full 2 days. So hopefully everybody appreciates that. We tried to cover a good high-level overview this evening on extractions and grafting. We obviously can't get into the detail that we do in our programs based on the time restraints, but hopefully everybody still found it to be beneficial or picked up a couple tips this evening. So to clarify, the physics forceps sets, this is the one that's been around since 2007. This is the standard series set. If anybody does not have our product currently, this would be the set to start with. It's going to generally do second molar to second molar on the upper and the lower. Based on the design of the instrument, you're not always going to get back to a second molar based on the access, and you're surely not going to get back to an erupted third molar. This is what this set's designed for. This is called our molar series set. This set is going to go into the mouth at a different angle and allow you to access erupted third molars and what we consider to be hard to reach second molars. So the whole purpose of these is really to get further back into the mouth when the standard series won't allow you to get back there based on an access restriction. The reason I say that everybody would always start with the standard series first is because you really do get better leverage with the standard series based on the design of the instrument. It's going to be a simple up or down rotation of your wrist, where the molar series that I'm showing now is a little bit of a different instrument where it goes straight in the mouth, but envision turning your wrist like turning a round doorknob, sort of in slow motion. So you lose a little bit of your leverage with this instrument, but it does allow you the purpose of, or the means, I suppose, to get further back into the mouth to be able to get to those erupted thirds if you're interested in doing wisdom teeth in those second molars where a patient maybe has smaller mouth or access that you can't get to with the second molar. The other nice benefit real quickly about the molar series is the bumper with this instrument, the yellow bumper you see in the image, that can be placed on the buccal or the lingual aspect of the tooth, where that is unique to the molar series, where the standard series, the bumper is always going to be on the buccal side. So it does provide you a little bit of flexibility based on the angle of the root or maybe the condition of the tooth. There are going to be some instances where maybe it makes sense for you to place the bumper on the paddle or the lingual aspect of the tooth. So those are the two sets really that we do offer here. The separators, this is a new series for us. This is the physics forceps separators. We worked with Dr. Ara Nazarian, which is also one of our instructors that Tim mentioned earlier in the program. When you're going to place an implant, you obviously want to be very careful with the tissue and the surrounding bone. And there were certain cases where sometimes Dr. Nazarian liked to use an instrument like these that he helped us develop in advance prior to using the physics forceps. It's not something that is necessary to use, but there's certain times that if you want to be extra careful, so to speak, and ensure that you're going to have a perfectly atraumatic extraction site, this is going to be a good instrument to take a look at. We've had really great feedback on them. We've actually, our first batch we had actually sold out quickly, and they've been successful. It's something to take a look at. There's a straight, a curved, and a bayonet. There's other kits out there on the market that maybe have 10 or 12 of these types of instruments. And we found with working with Dr. Nazarian that it was too complicated, too many instruments. We boiled it down to really what you're going to need here to serve the same purpose as some of those more complicated kits. So something to take a look at. Again, these are called separators. These are new for us here at Golden Dental. The other thing that we added, you know, sometimes you're going to have to, you know, dig a root tip out. It can happen with, you know, any instrument, or if the patient presents with a root tip. You know, we like to say with the physics forceps, it's very rare to break a root tip because of the motion of the tooth. You're not really rocking it back and forth. But when it does happen, you know, it can happen in some cases with really any instrumentation. These are two root tip picks that we use in our program that we added to our separator series. Dr. Golden loves these. He's been using these really for 45 years, and so we started to make these a little less than a year ago and have them as part of our separator kit. They're very strong, they're thick, they're not going to bend. A lot of the other root tip picks out there, we found in our experience, are a little bit too flimsy. So these are really going to get the job done to be able to get the root tip out effectively. So regenerative materials, if anybody is grafting or considering getting into grafting, Tim showed this kit, so I won't spend much time on it, but it's a Kosinski graft kit. Tim worked very closely with us for us to manufacture and design exactly what he uses every day. We kept it simple, like he said. And this is a real nice kit if anybody's looking to get into grafting, or maybe if you want to pick up a new curette or whatever. We do have them, obviously, individually too available. But this is a nice kit. And the other thing is we have the allografts and the Cerasorb and osteogen and different products we showed available on our site and through our company. I think if you look at our allograft pricing and even different pricing on Cerasorb, I think you'll actually find it quite competitive. We do have customers that have switched to use our allograft that actually used to pay more than double from different companies out there like Zimmer and other people that do sell bone. So if you are using bone products or you're just getting started with it, appreciate it if you take a look. I think our pricing is actually very competitive and might be something that can save you some money. Real quick, live patient programs. We offer a couple programs here in Detroit. We have a one-day extraction program, and we have a two-day program, which is extractions and grafting. Tim Kosinski, the presenter this evening, is one of our instructors, along with our Nazarian shown in this picture, and then Dr. Richard Golden. Great program. We truly believe that to learn effectively, live patient work is really, there's no better way. So it's not a cadaver program, not really a hotel course where you're going to sit in a hotel and work on models. We have plenty of patients at the university that we work in. You know, 80 plus patients every program. We turn patients away every course. There's more than enough extractions and grafting to get the experience. This is the facility here. We usually have you partner up with just one or two other doctors. Usually in the afternoon you work by yourself as you get more proficient. But it's a great facility. Really anything you can think of is available to you here at the university. Again, just another photograph. So it's a nice facility. You really get the experience of, you know, like going on a mission trip or having to, you know, go out of the country to get some of this live patient training. We offer it here in Detroit, better than the other programs where you're going to have to travel out of the country. It's easier to get to, and you really are going to get the same amount of experience from a live patient perspective. Here's just one last photo. Here's Dr. Kosinski assisting a couple of our attendees at our last program. And then lastly, I guess this is what I guess some folks are waiting for. So what we're going to do here this evening is we believe in our product with the physics forceps. We know once you try the product, you know, it's a very large percentage that keep the product. They're happy with it. You know, would have been happy to even pay double the price because it's so effective for them. So what we're going to do, which we've never done on a webinar, is if anybody wants to try the standard series set, which is normally retails around $1,500, we'll let you try it for $1. So with using the code 1, so it's a CODE1, it will take the pricing in the shopping cart of $15.85 and make it $1. If you've got 30 days to try the product, and many patients as you want, comes with plenty of bumpers, a great training DVD. If you don't like the product for any reason, simply send it back and you spend $1 to try it. If you keep the product, we'll still go ahead and honor you the promotional pricing of a 15% discount, which is still a great price. If you keep it, you're still going to take advantage of the 15% off, but you got to try it for a really low price of $1 just to see if you believe in the product. Something we've never done. Don't do it at trade shows. And actually at trade shows, we only really offer a 10% discount. So the webinar really is the best promotion, and we encourage you to take advantage of it. Option 2 is if you want to try any of our products, any of the regenerative materials or the graft kit or anything you might have seen this evening, osteogen plugs, go ahead and put in the code. It's code 15, so it's CODE and then the numeric 15. That will give you a 15% off discount on any of our products, and this also includes our CE programs. So that's a great deal too to take advantage of. So with that said, they're great specials. We don't keep them around long. 24-hour special, expires tomorrow. We're pretty strict on that, so if you want to take advantage of anything, we encourage you to give us a call at the number on the screen. Visit physicsforceps.com. Go ahead and try the code 1 or the code 15 promotional offers, and we encourage you to do that. If anybody, we always have this come up, if anybody is having trouble with the codes, just complete your order, write a little note, you were on the webinar, we'll fix it on our end, so don't worry about that. The other thing too is the website will only accept one code at a time. Somebody wanted to try the Physics Forceps for $1 and maybe order a box of osteogen plugs, you're going to have to do them as 2 separate orders or give us a call, whatever's more convenient for you. So I'll go ahead and I guess leave this on the screen, and I'll get to the Q&A session here so Tim can get to some of the questions that are coming in. All right, so the first question that I see that's coming in here is, if I use osteogen, is that a bone graft or is that a socket preservation? What codes do I use, and how do I get reimbursed? Tim, I guess we get that one quite a bit. I don't know if you want to take that one or not.
I'm going to let you do. I don't know the codes, Kurt. If you want to do that, or you could get that to the questioner.
Well, I think we show the codes in the presentation. In our live patient programs we do. However, I think the messaging has always been, sure, you can try the codes, but a lot of it, I believe, is not covered. I think that's your prior experience, right, Tim?
Right. Grafting is not normally covered by any dental insurance, but the osteogen is it's going to convert to bone. So socket preservation and grafting, in my terminology, is the same thing. So it's used. I use it very predictably when I have a socket, when all 4 walls are intact. That's what its intended use is. Now there are some more advanced techniques that we're demonstrating, but we did not demonstrate that today. And I think for those who are a little bit less experienced with the product, I would use it only with a socket where all the walls are intact.
Okay, perfect. Maybe I'll get all the osteogen questions out of the way here. So is primary closure critical when using osteogen? Because I know you mentioned in the presentation you don't use a membrane.
No, primary closure is not important. What's very important in our implants, and again, it's a great question, and thank you. I want to maintain the attached gingiva and the facial aspect. So I don't want to pull mucosal tissue onto the facial aspect. So no, primary closure is not critical. And the epithelium will grow over the top of it rather than invaginate into it.
Okay, perfect. Let me just see for osteogen real quick. I guess somebody has asked, have you used foundation, or is osteogen like the product from J. Marita called Foundation.
Great question. It's not the same product at all. Osteogen has been used in Europe for about 30 years, and it's been brought over to the United States. It's a very particular, and if you Google it, you'll get the specifics from the company. The manufacturing of the calcium and phosphorus products, it's a non-sintered product, which is very osteoconductive, meaning that we get turnover of the bone very nicely. So the chemical composition is totally different than foundation. I've used foundation. I don't find it to be an ideal socket preservation, meaning I don't get the turnover of bone that I get with the osteogen product. It's not the same thing.
Okay, and I guess they added that too. I've heard that the foundation was a little bit more, from a feel perspective, was more like a collagen plug where you could maybe roll it up and bend it a little easier, with a little more flimsy. Where the osteogen, just from a handling perspective, I think it's more dense. Just to add to that. Somebody asked if there's any specials on osteogen. Yeah, of course. If you use code 15, it's 15%. Osteogen is, the box is normally, for 5 in a box, it's normally $250. So I guess if you take advantage of the special, the plugs are normally about $50, and I think if you take the 15% off, it's a pretty inexpensive graft without a membrane. I think it brings it down to about the $40 range per plug. So if you want to take advantage of any specials in the osteogen, then you'd want to use the 15% off coupon. Let me see here. Okay, I guess I'll get to a couple of physics forceps questions, I guess. I guess, Tim, you get this question a lot too. Do you elevate in advance, or is the forcep really an elevator?
Again, great question. I've seen it used both ways. I personally, to be honest with you, I do not elevate first. I don't take a periotome. I don't elevate. I go right to the physics forcep and use it. It's more of a luxator. I wish they didn't even call it a forcep, because it really is creating tension on the periodontal ligament, which is similar to what a luxator would do, breaking down the periodontal ligament, lifting the tooth up and out. So I personally don't luxate first.
Okay, great. Tim, this is an interesting question, I guess. Since they're a little bit new, and I know you've been using the separators a little bit more recently, so this is a good question, I guess. It says, when do you decide to use the separators versus making a lingual purchase point with a 557 burr and only using the physics forceps? So I guess what they're saying is, in order to get that grip or engagement with the beak, I suppose you could, when would you maybe use the separators to push away the tissue a little bit to get the beak in there, or I know historically you've used the 557, but I don't know what your thoughts are on that.
Well, yeah, the separators. What's nice about the golden separators is they're high quality, and they don't bend, and they're used for root tips mostly. That's when I would use them, when I'm trying to get a piece of a root tip out, is when I would use the separators most often. Okay,
osteogen, ideal heal time prior to implant placement, 3 or 4 or 5 months?
Yeah, again, you can radiographically determine the turnover, because the radiolucency of the material will become more bone-like, more radio-opaque over time. And I would say 4 months is a very safe time. Sometimes I'll wait 5. It all depends on it all depends on the socket that you had to start with. If you had that molar I showed you was like a cereal bowl, I'm going to allow more time for a regeneration of bone, as opposed to a skinny root that's only 5 or 6 millimeters into bone. So it all depends on the socket site that you created.
Okay, perfect. Somebody, I guess we have somebody's using the physics forceps on a lower molar. sometimes the patient might complain of pain in the TMJ. Do you ever use a bite block?
Absolutely, yes. On the contralateral side too, that's where they'll have their discomfort. And that's why I like to section lower molars and just take them out so you don't have that tension. But yes, a bite block is a great idea.
Okay, I think you covered this, but somebody did ask too a question about do you ever section upper molars, and when do you section a lower molar? I think you covered that, but maybe you want to.
Almost always lower molars, and never upper molars, because the bone is medullary, it's soft, and I don't section upper molars at all.
Okay, so for the lower molars, it's more when they're like divergent.
Yes, of course, yeah.
Okay, what else we got here? I guess some people, just to clarify, just to go over real quickly the technique, I guess, you know, it says, do you squeeze at all? Can you explain the rotation of your wrist a little bit again, please? And then somebody even asked a question about having apparently a hand injury and whether the hold of the instrument would be ideal for somebody that, you know, maybe doesn't have a lot of strength in their hands.
You know what? That's a great question. So the working end of the instrument is the beak, which engages the palatal or lingual aspect. We're not squeezing the handles at all, so you need no strength. You need no muscles. You need no bicep. You need no shoulder. There's no squeezing whatsoever. You're holding the handles firmly, and you're rotating so that you're creating tension on that lingual or palatal aspect of the root. Remember, the bumper is just the center of rotation. It's a fulcrum point. That's all. It's a lever. It's like a bottle opener. You know, it doesn't take a lot of strength to take a bottle cap off of a bottle. And basically that's the philosophy. And the rotation is simply of your wrist, creating tension onto the beak, onto the tooth.
Okay, I guess this is a question we get a lot of times too. This doctor says, you know, bone's important to me. I place implants. You know, how can I feel comfortable that the physics forceps won't damage the bone? I guess.
I think it comes with practice. I think coming to one of our courses, I think, you know, taking 20, 30 teeth out, and you'll get pretty proficient at it.
Yeah, and I think the key is they're not to squeeze, obviously, right? So the bumper is your fulcrum or your pivot point, so you should not be putting you know, a lot of pressure on the bumper to be damaging the bone.
Correct.
But so I think in our experience, I mean, it, you know, can happen with anything sometimes, of course, but it's pretty rare. All right, let me try and get just two more questions here. Do you somebody was asking about flap design. I don't know if you can answer that quickly or not, but do you want to explain this quickly? I guess again.
Well, you know, and to keep it real simple. So if you think you have a defect, or you're not sure, then you have to elevate the tissue away from the defect. And you have to do whatever you have to do to be able to see the defect. And if you're going to use a membrane, as I said several times, you have to place the membrane beyond the defect. So if we can do it without making vertical incisions, obviously it's more conservative and less traumatic, and you have more control. But if you have to make vertical incisions, one thing I didn't have a chance to discuss is try to keep your vertical incisions in the attached gingiva. Try not to go into mucosa. When we go into mucosa, there's a lot of prostaglandin release, and that's when patients have a lot of discomfort. So, you know, again, and it's hard to do this as a voiceover without showing it. I guess the best analogy I can use, Kurt, is like a white envelope, you know, the long envelopes that we have. And if you take the flap and you lift it up and you blow into it, you're kind of pushing the sides and opening it so that you can actually see the defect.
Okay, perfect. I guess I'll, you know, just to respect everybody's time here, I know we're maybe a little bit over. I'll take the last question here. It just says, for the live patient CE, do I need a Michigan license? The answer is no. Anybody from Canada or the U.S. that has obviously a U.S. or Canadian dental license, it's not going to be an issue. And the reason is we we do all of our programs at the University of Detroit, which is a teaching facility, and it's not an issue for our programs. All right. Well, I guess there's a few more. I guess we'll email maybe some people privately to get to a couple of their questions. We're obviously available at our phone number here, or you can contact us through email or give us a call. We can pass the questions along to Dr. Kosinski. It's no problem. And I hope everybody enjoying the webinar this evening. Again, if you're interested in the products, give us a call. If you have any technical questions, give us a call. We're here to help. Thank you, everybody. Thanks, Dr. Kosinski, and I hope everybody has a great evening.
Good night, everybody.